Welcome. Today we're diving into some radiation biology that really hits right at the heart of long-term quality of life for our patients.
hmm
We're going to unpack the late effects of radiation on, well, some really sensitive normal tissues,
hmm
the gonads, testes, and ovaries, and also bone.
Right. And with bone, it's key to separate growing versus mature bone. They react quite differently.
Exactly. So we'll look at the difference there.
And thinking about these long-term effects is just, fundamental and rad on Sequel. We've touched on other organs before, brain, lungs, heart, kidneys.
Right.
But focusing now on gonadal and skeletal health really highlights why understanding these sensitivities is so essential. Not just for planning, but for counseling patients too, about life years down the road.
Yeah, absolutely. This session should hopefully consolidate those critical principles, especially, as you're prepping for boards.
That's the goal.
Okay, so let's start with where the sensitivity is really striking.
Hmm.
The male gonads, the testes, what are the key functions we're worried about protecting?
Well, primarily you're looking at two things: sperm production, spermatogenesis, and testosterone synthesis.
Okay.
And the most vulnerable part, radiosensitivity-wise, is the germinal epithelium, specifically the stem cells involved in making sperm.
Right, the stem cells. So digging into that cellular hierarchy, which ones are the most sensitive?
Okay. So at the very bottom, the foundation are the spermagonia. These are the primitive stem cells. They're actively dividing, and they are incredibly radiosensitive.
How sensitive?
We're talking damage you can detect at doses like zero point 0.1 gray. That's only 10 centigrade.
At a 1.1 gram.
Yeah, they are, frankly, among the most radiosensitive cells in the whole body.
Okay, so damage to these cells seems like the main issue for fertility then.
Absolutely. It's the damage to spermatogonia that primarily drives those radiation-induced drops in sperm count. You get oligospermia, low sperm count, or even sterility. And that can be temporary or it could be permanent.
How low a dose are we talking for temporary sterility?
You can see temporary sterility with doses as low as, say, 0.15 gray, so 15 centigrade.
15 centigrade. Wow.
Yeah, and recovery is possible if enough stem cells survive to, repopulate things over time.
Okay. And for permanent sterility, to really knock out that stem cell pool for good.
For a single dose, you're looking at around 5 to 6 gray.
Okay.
But here's a really critical point, maybe a bit counterintuitive from standard radiobiology.
Mm-hmm.
For these super-sensitive, rapidly dividing spermatogonial stem cells, standard fractionation doesn't actually provide significant sparing against permanent sterility.
Wait, hang on. So you're saying fractionating the dose doesn't protect against permanent sterility like it might for, say, lung or kidney?
Exactly. Because the stem cells are so sensitive and they're cycling through division, fractionation just gives you multiple shots at hitting and killing them before they can really repair or repopulate effectively.
Huh.
So with conventional fractionation, the total dose needed for permanent sterility is actually lower. It's down around 2.5 to 3 gray total.
2.5 to 3 gray fractionated.
Right. That's a key nuance, definitely one for boards and clinical practice.
Yeah. That really is a crucial distinction. Okay, what about the timing? Is the patient infertile, like, right away?
No, there's a lag period. It takes roughly 74 days for spermatogonia to mature into sperm.
74 days, okay.
So even if you wipe out the stem cells, fertility can actually hang around for a bit, using the sperm that were already mature when the radiation hit. The sperm count drops over the next few weeks and months.
Okay, so fertility is highly sensitive. What about the other function, testosterone production? Hormonal function?
Yeah, this is another interesting contrast. The Leydig cells, the ones that make testosterone, are actually pretty radioresistant compared to the spermatogonia.
Ah, okay.
So you often see radiation-induced sterility happen without a significant drop in testosterone levels or libido.
So someone could become sterile from the radiation, but still maintain normal male hormone function.
Exactly. That's the typical scenario, unless you deliver really high doses. We're talking over 20 or 30 gray directly to the testes. Then you could potentially damage the Leydig cells too, but sterility usually happens at much lower doses, affecting just the germline.
Got it. That covers the male side well. Let's pivot now to the female gonads, the ovaries, primary functions here, and what's the really fundamental difference from testes in how they respond to radiation?
Okay, ovaries. They house the oocytes, the eggs, and they produce estrogen and progesterone. The fundamental, absolutely critical difference is females are born with all the oocytes they'll ever have, a finite pool.
Right.
There are no stem cells regenerating oocytes throughout life. None.
No stem cells.
Yeah.
That changes the whole picture for long-term effects, doesn't it?
Completely. Any radiation damage to this pool is cumulative, and it's irreversible. You're essentially just
Yeah.
depleting a non-renewable resource.
Okay. And within the ovary, how does the radiosensitivity vary? Are all eggs equally sensitive?
No, the sensitivity varies with the developmental stage of the oocyte. In humans, the most sensitive stage are the primordial follicles. These contain the really immature oocytes.
And the more mature ones, the ones developing.
The developing and mature follicles are generally a bit more radioresistant than the primordial ones, but again, hitting any stage reduces that irreplaceable reserve.
So sterility in females is basically about hitting a certain threshold of oocyte loss.
Exactly. Permanent sterility happens when you deplete that total pool below the point where normal cycles can happen. And the dose needed for that is highly dependent on one major factor:
Which is?
age.
Age. Why is age so critical here?
Simple reason. The ovarian reserve naturally goes down with age. So an older woman, especially one getting closer to menopause, starts with a much smaller pool of oocytes than, say, a young woman or a child.
Oh, makes sense.
Which means it takes a significantly lower radiation dose to wipe out that smaller reserve and cause permanent sterility.
Can you give us some approximate dose ranges for that age effect?
Sure. So for a woman in her 40s, let's say, approaching menopause, you might induce permanent sterility with doses as low as 2 to 3 gray, conventionally fractionated.
2 to 3 gray. Wow.
But for younger women, starting with that much larger reserve, you need higher doses. It's variable, but figures like 10 to 15 grays in childhood are sometimes mentioned, though interestingly, the prepubertal ovary might actually tolerate a bit more than an adult ovary would before sterilizing. It's complex.
That difference is huge. Though 2 or 3 gray versus maybe 10 or 15, that immediately makes you think about clinical practice.
Absolutely. And that's why understanding this age dependency is so vital for counseling and planning for any female patient getting radiation anywhere near the pelvis or abdomen, whatever her age.
Right.
It's also why historically radiation was sometimes used for ovarian ablation in premenopausal breast cancer doses. Around 5 to 10 gray were often enough.
And what about hormonal effects in females? Is it like males, where function is often preserved despite sterility?
No, that's another key difference. Radiation-induced ovarian failure sterility is almost always accompanied by a loss of hormonal function.
Always. Why is that?
Because the developing follicles, which get destroyed along with the oocytes, are the very things responsible for producing estrogen and progesterone.
Ah, okay.
So when you deplete the follicular pool, hormone production just stops. This leads directly to premature menopause.
Which brings its own set of problems beyond just fertility loss.
Exactly right. You get the classic symptoms: hot flashes, vaginal dryness, mood changes, and importantly, you increase the long-term risks of things like osteoporosis and cardiovascular disease because you lose estrogen's protective effects.
Okay, that's a really stark contrast between males and females regarding hormones post-sterility. Right, let's shift gears again onto bone. You mentioned its response is really tied to maturity. Let's start with growing immature bone.
Yeah, for growing bone, the critical target cells are the chondrocytes. They're located in the epiphyseal growth plates.
The growth plates, okay.
And these are the cells driving longitudinal bone growth, making bones longer. And they are highly radiosensitive.
So what happens when radiation hits these chondrocytes?
Well, you damage or destroy them, and that leads directly to growth arrest. Basically, the epiphyseal plates close up too early.
Resulting in shorter bones.
Shorter bones, yes. And potentially deformities, too.
Deformities. How so?
If the radiation field isn't perfectly even across the growth plate, you can get asymmetric growth arrest. One side stops growing, the other keeps going. If that happens in the spine of a growing child, for instance, you could end up with scoliosis.
Okay. What sort of doses are we talking about to cause these effects in growing bone?
Growing bone is sensitive, even at relatively low doses. You can see detectable disturbances in growth with doses as low as maybe 4 to 10 gray.
4 to 10 gray.
Yeah. And significant growth arrest is typically seen around 10 to 20 gray. Higher doses, of course, mean more severe and permanent stunting.
This clearly makes pediatric radiotherapy anywhere near bone incredibly challenging.
Oh, it's a huge consideration. Minimizing dose to growing bones, and especially those epiphyseal plates, is one of the absolute top priorities in pediatric planning.
Right.
And it often drives our technique choices. It's a major reason why you might favor something like proton therapy, which can potentially spare those growth plates better than photons because of the sharper dose fall-off. Field design is also critical.
Okay. Now switching to mature, adult bone. Is it anywhere near as sensitive as the growing kind?
No, mature bone is considered relatively radioresistant compared to many other tissues, at least. The cells in adult bone, your osteocytes, osteoblasts, osteoclasts, they turn over much more slowly than those rapidly dividing chondrocytes in the growth plate.
But relatively resistant doesn't mean immune, especially at higher doses.
Absolutely not immune. Even with that slow turnover, high doses to mature bone can definitely lead to significant late problems. The most famous one is probably osteoradionecrosis,
ORN,
or in a
which is essentially bone death caused by radiation.
Exactly. Death of the bone tissue. It's often complicated by poor healing, maybe infection. The classic site everyone thinks of is mandibular ORN after high-dose radiation for head and neck cancer.
Right.
And the thinking is it's caused by a combination of damage to the blood vessels supplying the bone and damage to the bone cells themselves.
And fractures are another risk.
Yes, irradiated bone becomes more brittle, less resilient, so it's more susceptible to pathological fractures, sometimes even without major trauma or with this minor injury. You can also see other changes like sclerosis, where it gets denser, or atrophy.
What dose range really puts mature bone at significant risk for these big complications like ORN or fracture?
The risk really starts to climb significantly once you get above doses of, say, 50 to 60 gray delivered with standard fractionation.
Bacteria 60 gray.
Yeah. The TD55, the dose for a 5% complication rate at 5 years for necrosis or fracture, is often quoted right around 60 grays, especially if you're talking about irradiating a decent volume of bone.
So while it's tougher than growing bone, mature bone definitely has clear tolerance limits we have to respect when we plan treatments.
Exactly. It comes down to looking at those dose volume histograms, respecting those constraints, especially in areas like the mandible, the pelvis, the ribs, places that might get caught in a high-dose field.
Okay, we've covered a lot of the core biology. Let's try and pull this together with some, must-remember points for clinical practice and for board exams.
Yeah.
Our sort of clinical pearls from this discussion.
Okay, let's do it. Pearl number 1. For the testes, remember spermatogonia are incredibly sensitive. The dose for permanent sterility with fractionation is surprisingly low, maybe 2.5 to 3 gray total dose. Significantly lower than a single dose because, remember, fractionation doesn't spare these cells well. And crucially, hormonal function testosterone is usually preserved unless you hit the testes with really high doses.
Okay, pearl 1 was number 2.
Pearl 2, ovaries. High sensitivity, especially those primordial follicles, and the big one, no stem cells for regeneration, damage is permanent. Sterility dose is highly age-dependent, much lower for older women. Remember that 2 to 3 gray figure for someone in their 40s?
Right.
And sterility is directly coupled with hormonal failure, leading straight to premature menopause and all its associated risks.
Okay, pearl 3.
Pearl 3, growing bone. Target cells are those highly sensitive chondrocytes in the epiphyseal plates. The main risks are growth arrest and deformities. And remember, these can happen at relatively low doses, detectable effects starting around 4 to 10 gray, significant arrest around 10 to 20 gray. This really drives how we approach pediatric RT.
Makes sense. And the last one, pearl 4.
Pearl 4, mature bone. Relatively radioresistant, yes, but at high doses, think above 50 to 60 gray, you face real risks of osteoradionecrosis and fracture.
Excellent. Those are definitely the essentials to lock in.
Mm-hmm.
Speaking of essentials, let's do a quick board review blitz based on what we just covered. You ready?
Let's go.
Question 1. Which cells in the male gonad are most radiosensitive? A. Leydig cells, B. Sertoli cells, C. Spermatids, D. Spermatogonia.
That's got to be D. Spermatogonia. The dividing stem cells, super sensitive.
Correct. Question 2. A 42-year-old premenopausal woman receives pelvic radiation therapy. What's the approximate total dose of conventionally fractionated radiation likely to cause permanent ovarian failure? A. 0.5 to 1 gray, B. 2 to 3 gray, C. 10 to 15 gray, D. greater than 20 gray.
Okay, 42-year-old, smaller reserve. That points to be 2 to 3 gray.
Exactly right. Question 3. A child gets radiation therapy, including the epiphyseal plate of a long bone. What's the most significant long-term risk to that bone? A. Acute osteomyelitis. B. Pathological fracture within 1 year. C. Osteosarcoma development within 5 years. D. Growth arrest and shortening of the bone.
Damage to the growth plate. That means problems with growth, so D. growth arrest and shortening.
Nailed it. Okay, last one. Question 4. Which statement correctly contrasts the typical hormonal effects of radiation-induced sterility in males versus females? A. Both usually keep normal hormonal function. B. Both usually lose hormonal function. C, males lose it, females keep it. D, females typically lose hormonal function causing premature menopause, while males often maintain testosterone unless doses are very high.
Okay, contrasting them. It's about which cells get hit at sterility doses. Spermatogonia go first in males, leaving Leydig cells often okay. In females, the hormone-making follicles go with the oocytes, so that points to D.
Perfect score. So thinking about all this, it really underscores how complex it is balancing killing the tumor with, preserving these vital normal tissue functions. Shielding seems critically
Oh,
important.
absolutely. For gonads, especially in younger patients where fertility and hormones are huge issues, careful field design and actually shielding whenever you possibly can is just non-negotiable. And that leads right into fertility preservation counseling, sperm banking, egg or embryo freezing, maybe ovarian transposition. That conversation has to happen for any reproductive aged patient facing radiation that might affect those areas.
Definitely. And for bone, particularly in kids, that sensitivity of the growth plates really drives home why precision and maybe using advanced techniques is just so vital.
Yes, the risk of permanent growth problems, deformities. It forces us to be incredibly careful with dose to growing bone. It's one of the clearest examples where radiobiology directly tells us which techniques might be better, like considering protons.
Right.
And even in adults, yeah, bone is tougher, but knowing those dose limits helps us avoid devastating things like ORN, which can really impact quality of life.
So it seems the overarching message across all these tissues is kind of nuanced, right? They have different sensitivities, different key cells we worry about, different patterns of long-term effects. But understanding the specifics for each one is absolutely key to minimizing that long-term harm.
Precisely. It's about really appreciating the vulnerability of those actively dividing stem cells, like spermatogonia and chondrocytes. Understanding the tragedy, almost, of damaging an irreplaceable pool like the oocytes. And recognizing the cumulative damage that high doses cause, even in slower tissues like mature bone.
Okay, so quick recap then. Testes spermatogonia, super sensitive, low sterility dose with fractionation, but hormones usually okay.
Right. Ovaries, oocyte sensitivity, no stem cells, very age-dependent sterility dose, and sterility means premature menopause.
Growing bone chondrocyte sensitivity and growth plates, risk of growth arrest and deformity, even at moderate doses.
And mature bone, relatively resistant, but watch out for ORN and fracture risks above 50-60 gray.
Mastering those differences really seems fundamental to practicing smart radiation oncology and getting the best long-term results for our patients.
Couldn't agree more.
So maybe something for you to think about as you go through training and into practice. How does knowing that specific age-dependent ovarian sterility dose range, say 2-3J for an older woman versus 10-15J for a younger one, how does that actually change the conversation you have when consenting a 25-year-old versus a 45-year-old for pelvic radiation, even if the tumor dose is identical?
That's a critical clinical exercise right there, really thinking through that implication.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.